Thank you so much to all the speakers. We are now going to move to the Q&A section. And we are going, do we have all of our speakers here? Just checking.
Can you hear me?
I think they're coming on now. There we go.
Hi.
Hold on.
Okay,
Fantastic.
So we're going to start with question for Natalie. Question is, is there any correlation between EDS and ovarian cysts?
No, ovarian cysts can occur, of course, in any woman at any time, but there's no particular increased risk for ovarian cysts in association with EDS.
Thank you very much. And moving down to Professor Khullar, how common are bladder emptying difficulties in people with EDS?
It's about a third of patients who end up with bladder problems. And overall, when we look at bladder problems as a whole, it's probably a third. So it works out to around 10%. So 10% would be the overall number who would have a definite problem with emptying their bladder, but the actual symptom of finding it difficult to empty or feeling that the bladder's not emptying is actually much more common, and it probably comes to around about half. So one is probably inflammation of the bladder, and therefore it never feels quite empty, but then the inflammation can get so severe that the muscles go into spasm, and then the bladder doesn't empty properly, and then people can end up self-catheterizing. So it's almost like a two-stage process.
Thank you very much. And now to Dr. Russo, I believe you're on the phone with us. Can EDS cause issues with egg implantation?
Can you hear me? Hello?
Yes, we can.
Okay.
Did you hear the question?
I did. And I have video here, but I guess it's not showing up.
Let's see if we can get one of our team to help you with that.
But anyways, I can just answer the question. So egg implantation is part of sort of the fertility process. And I think there was a slide in the PowerPoints that talked about infertility. And it does seem like women with EDS have a much higher rate of infertility. I think we're still in the beginning stages of really understanding why this is, and if this is something that's really just, if it's part of or related to EDS, or that, you know, women potentially have a higher risk of other problems that can lead to problems with egg implantation, like if they have endometriosis or polycystic ovarian syndrome or some other problems that could contribute to infertility. I think it's one of those things that we don't know if it's necessarily related to Ehlers-Danlos syndrome, but these women may have a higher rate potentially of these other problems that do lead to infertility.
Thank you so much. And Dr. Blagowidow, these issues, of course, don't just face women. And do the issues we see affect trans men with EDS at the same rate as cis women?
So could you be more specific in what particular effect are you talking about?
The gynecological conditions that you spoke of. That's the question I have.
So you mean somebody who is a female who has trans to become a male but still has her female functions? Oh, of course, you know, those issues are going to continue unless measures have been taken hormonally or surgically to remove, you know, if you have a hysterectomy and your gonads removed, some of the issues that I spoke about will no longer be an issue. But if you're continuing to menstruate, absolutely, you'll continue to be at risk for the problems I talked about.
Thank you. And Professor Khullar, sorry, just having a look here. Can instability in the neck lead to bladder incontinence?
Absolutely. If it affects the spinal cord, and patients can then get problems with overactivity, and also they can get problems with voiding. And in fact, if there is a problem with sensation or a change with the way the bladder functions, and at the same time the person's getting very severe neck pain and they're known to have instability, that would be a key thing to get the instability examined, because there could be compression of the spinal cord occurring.
Thank you. And Dr. Russo, is there a higher risk of breach, transverse lie, or unstable lie in hypermobile EDS? And do you have any specific advice on how to approach this?
Yes, there has been described that there may be a higher chance of a baby being breech or transverse, which means, just for all the, to make sure everybody's on the same page, that's if the baby's bottom or feet or something other than the head is sort of lower than would be coming out first. This may be related to the relaxed connective tissues. And I think the second part of that question was, is there anything to do about this? So later on in your pregnancy, the doctor or provider will check to see, they can feel the position of the baby on your belly. They can also do an ultrasound. There is the option to do something called a version, but that's something that I would say is a very individualized thing, because the way we change the position of the baby is sort of with our hands pushing the baby to bring the head down. I don't think it's an absolute contraindication to not do it in someone with Ehlers-Danlos syndrome, but I think it really just depends on what's going on in your individual body, and it's a discussion of whether you'd want to do something like that during the pregnancy, depending on what your issues are.
Great, thank you. And back to Dr. Blagowidow. So are those with a type of EDS more likely to develop ovarian cysts? Oh, sorry, I think I've read that. Have I read that one?
You did.
Okay,
of course,
sorry.
Polycystic ovary syndrome is a little bit different, which again, no increased risk, but is not uncommon, and you will see that in EDS, but that's more of a hormonal diagnosis than literally large cysts.
Thank you. And while we're with you, is cystitis related to EDS?
That's over, probably more to Dr.
Yes,
Khullar,
let's move to Professor Khullar for that one, if that's okay.
Yeah, I think he's better to answer that.
What's been interesting is that, you know, I'm coming more and more to the conclusion that EDS is associated with an abnormality of the immune system, and the immune system then generates certainly things like the problems with UTIs. We now know that endometriosis, there's a gene relating to the immune system, and therefore it's also now being considered very much an immunological disorder. But cystitis involves a particular interaction between the body's immune system and the bacteria. And what is most interesting about women with, or men and women actually with Ehlers-Danlos, is they don't generate that. It's very rare you'll ever see the cystitis-like symptoms. They'll complain of increased urinary frequency, probably passing urine at night, and the classic thing is passing urine a number of times. You know, they'll lie down in bed, get ready for sleep, and then need to go a few times. But the cystitis, which is burning and stinging to pass urine, won't really happen. And if there is a very severe infection, then often people will complain of actually seeing just basically blood in the urine. It'll almost go from 0 to 70 without any gap in between. So it's interesting. You don't really see the cystitis-like symptoms. But my suspicion is it's like we found this problem with urinalysis. So the standard test, which is done by all healthcare professionals when they're looking for infection. And we actually found that patients with EDS, 90% of them, even though they had an infection, 90% did not have an abnormal urinalysis, which is the exact opposite of the general population, where 90% will have a positive test. And that's probably why a lot of patients with EDS don't have their urine sample sent off for culture, because the doctors think, well, there can't be an infection. The stick test seems to show there's nothing there. But what's happening is they're actually testing the immune system, which is acting in a different way. So, and now very much, rather than thinking that patients with EDS have, often patients will say to me, oh, I've got a weak immune system. I don't think it's a weak immune system at all. If anything, it's overly aggressive. And it then means we as doctors are fooled into thinking, for example, there isn't an infection because the bacterial level will be low, but the immune system will be very aggressive.
Thank you, that's really helpful. And Dr. Russo, are miscarriages more common in any of the types of EDS or HSD, and how can they be prevented?
Yeah, I don't know why my camera's not working. I apologize, because anyways. So in terms of miscarriages, I don't think we really, we don't have any treatments per se to prevent miscarriages, besides sort of looking at things outside of EDS to make sure that there's no other factors contributing to that. But I do think it's worth working with potentially your OBGYN provider or working with a reproductive endocrinologist and infertility specialist to sort of figure out if there are any ways or other things going on that could potentially help modify your risks for miscarriage.
Thank you. And Dr. Blagowidow, what is the current evidence for hormonal contributions to EDS? And what are your thoughts on hormonal manipulation, especially any evidence for DHEA or low-dose testosterone for women?
Yeah, the literature really does not have any information that I came across in terms of testosterone or DHEAS use. Certainly, those medications, particularly in the postmenopausal period, can be very useful. So again, I think you want to just be looked at as an individual, look at your individual hormonal levels, and it can certainly be of benefit to use as a treatment if you have a deficiency.
Thank you. Professor Khullar, is a neurogenic bladder related to EDS?
The neurogenic bladder would really not be specifically related to EDS unless because by definition, it means that there is actually a neurological problem. But for example, if one had a problem such as a prolapse disc, and it was then pressing on the spinal cord, and we know that we see many more prolapse discs in patients with EDS, then for that reason, you would see more neurogenic bladders, but it's specifically because something has happened to the spinal cord leading to a bladder problem.
Thank you. And we can now see you, Dr. Russo. Hello.
Yes, hi.
What is the best age range to get pregnant for those with the type of EDS? And when, or if at all, is it too late?
That is a very individualized question. I think, we do know that, when you're younger, there's less risks in pregnancy. As you get older, there are going to be more risks. But that being said, in today's age, I think a lot of women are delaying having children until they get older. I think when the risks really start to go up for a lot of other problems in pregnancy is when you're getting past age 40 and we're going in, because like after 40, but I would never say to not have a baby, because some people meet their partners later in life. But younger is better. I think that that is sort of the general answer for that.
Thank you. And for Dr. Blagowidow, what is the relation between dysautonomia and hormones? Why is it that POTS symptoms worsen a lot days before and during a period?
I have to say that is out of my area of expertise. Hormonally, yeah, I don't really have an answer for why it would be worse.
I can see Professor Khullar with his hand up.
Yeah,
Maybe
good. Let him in. Sorry. But before we move on to him, I'm also demonstrating why you don't want me on a quiz thing where you have to answer really fast. Back to the previous question of DHEAS and testosterone. Of course, if the levels are elevated, we're back to polycystic ovarian syndrome, which we've already mentioned, but of course occurs in EDS as it does occur in the general population, and is treated in a different way. So that's not a deficiency. That's where you have a little bit too much, and there are hormonal manipulations for those as well. But anyway, I'll move on to get the answer on the dysautonomia.
You're doing great. Thank you.
So basically, what we have found with POTS-like symptoms, that if people have, if somebody has a urinary tract infection, their POTS becomes much worse. And there is now some evidence looking at the microbiome, of the gut, and it alters in the second half of the cycle. And also, obviously, you have the period itself, which is more inflammatory, and again, it will alter the autonomic function. So there's something about inflammation and changes in bacteria which seem to play a role, because it's very variable. It's not every single woman who says, in my progesterone phase, my POTS is worse. So there's probably something else in acting in the middle of it.
Thank you. And Dr. Russo, can pregnancy lead to uterine rupture in women with EDS?
Yeah, so we do think that there's potentially a higher risk of this, definitely in women that have vascular EDS. But I think with the other types of EDS, we think that vaginal delivery is safe. And a lot of women with hypermobile or the classic type 1 or type 2 can safely have a vaginal delivery. But with vascular EDS, we do know that there is a little bit of a higher risk than the general population. And for that reason, we do want people to, if you have vascular EDS, go through a C-section and not do a vaginal delivery.
Thank you. And Dr. Blagowidow, what would you say are the safest options for prolapse repairs for EDS patients? And what are the risks involved with a complete hysterectomy?
So again, depending which type of EDS you have and actually how fragile your individual skin or tissue is and how you've reacted to surgery can determine, the personal risks for you. Many women will do very well with surgery, particularly those individuals with hypermobile EDS, but then others will have very fragile skin, and in those cases, really the different surgical options, it's hard to determine which one, you can have difficulties and complications with any of them. There's no particular one that's better or worse. Certainly the least invasive, the less you do is the best. So these days, for example, for hysterectomy, the laparoscopic vaginal, sort of the dual approach, results in much smaller incisions, and then that's less tissue that needs to heal. So that's certainly an option to consider.
Thank you. And I think this might have to be our last question to Professor Khullar. Can urinary incontinence sometimes lead to the opposite, not being able to empty the bladder at all and needing to catheterize?
Yes, I think there's very much this dual thing that, you can have a little bit of inflammation, which makes the person pass urine frequently and then can lead to urgency incontinence. But on the other side, if we have too much inflammation, then the pelvic floor goes into spasm. Often these women will also complain of pain, for example, on incontinence, on intercourse, but at the same time, they then start to not being able to pass urine, or passing urine very infrequently. And then finally, the pelvic floor goes into real spasm and they can't pass urine at all, and they need to catheterize. So it's a continuum, and it really depends on how the person responds.
Okay, fantastic. Thank you. Okay, well, thank you so much to all of our speakers. That was a great session. We now have another 10-minute break, time to wriggle, wiggle, cook yourself breakfast, lunch, or dinner, wherever you are. Thank you again, and we'll see you in 10 minutes.